Hello, everyone, and thank you for joining us today. I'm Isra Pananon-Weeks, Interim Executive Director and Chief of Staff at the National Asian Pacific American Women's Forum. On behalf of NAPAWF and Ibis Reproductive Health, it's our pleasure to welcome you to our community briefing. Today, we'll discuss and share findings from our latest research that focuses on Asian American, Native Hawaiian, and Pacific Islander experiences with medication abortion. Here at NAPAWF, an important pillar of our work is building a research and data-driven movement that centers and uplifts the lived experiences of AANHPI women and communities. We know that there is little to almost no research that examines the reproductive health care and abortion needs of AANHPI communities. To help address this research gap, NAPAWF, along with the research team from Ibis Reproductive Health, conducted a 2-year study examining AANHPI experiences and knowledge of medication abortion. As we all continue to witness, abortion is under siege. Across the country, states are continuing to restrict access to abortion care and services. And as most of you know, the greatest of these assaults occurred almost a year ago when the Supreme Court overturned a constitutional right to abortion access established by Roe v. Wade. Now, the future of medication abortion, which accounts for over half of all abortions in the US, is under direct attack as a federal appeals court looks poised to further restrict or implement new restrictions on FDA's approval of mifepristone, or Miffy, one of the pills used in medication abortion. These pushes and attacks are happening despite Miffy's 20+ year track record of exceptionally safe use. Restrictions to abortion care are direct assault on communities of color, including Asian American and Pacific Islanders. 35% of pregnancies within the AANHPI communities end in abortion. It will always be a critical part of our reproductive health care. The research findings we present today offer a unique window into the challenges and setbacks AANHPI people face when seeking and accessing abortion care. If you have any questions, please type and drop them into the Q&A window, not the chat function, and we'll do our best to answer as many of them as possible during the Q&A portion. Today's briefing is also being recorded and will be shared out to our email listserv. And if you're not already signed up to receive our updates, please visit napawf.org/together to join. I'd also like to take this moment to acknowledge and thank our Community Advisory Board, also known as our CAB members. Today's research was conducted in collaboration with a distinguished group of community-based organizations, leaders, and experts on AANHPI issues. CAB members served as advisors and trusted thought partners throughout the research process. So it's my pleasure to welcome and introduce a special guest, Dr. Jennifer Chin, Assistant Professor at the University of Washington School of Medicine, who also served as a Community Advisory Board member for the Medication Abortion Research Project. As an OBGYN and Complex Family Planning Fellow at UW, Dr. Chin continues to carry out her longstanding passion for reproductive justice and family planning work. Welcome, Dr. Chin.
Thank you very much for having me.
And pleasure is all ours. So first question is, can you share with us what being a Community Advisory Board member for the Medication Abortion Research Project has meant to you, and why this work focusing on AANHPI communities is so important?
Sure. Again, thank you so much for having me, and it was an honor to serve on the Community Advisory Board. I'll tell you that I initially became interested in abortion work when I was a medical student, actually, at Tulane in New Orleans, Louisiana. I remember a very specific incident that sparked for me a great interest in abortion services and specifically in the field of family planning. I remember my OBGYN clerkship director, who was an Asian American, counseling a patient on her options for genetic screening for her pregnancy and telling her that she actually did not recommend any type of screening since it would not change her management of the pregnancy. I remember being appalled by this counseling. I knew that this patient, who was a low-income Medicaid patient who had received all of her care at the resident teaching clinic, would likely not have the resources to seek a second opinion or to be able to receive the genetic screening that she desired for this pregnancy, because my particular clerkship director did not believe in ending pregnancies, or that abortion was part of the full range of options in early pregnancy counseling. More importantly, my clerkship director was staunchly anti-abortion and wove this not only into her patient counseling, but also into her medical student and resident education. Throughout my clerkship and throughout the rest of my medical school training, I quickly saw what a devastating impact this had on current and future patients who would not receive their full range of options, nor would trainees who looked up to her for mentorship be equipped to fully counsel patients in a compassionate and non-judgmental way. I saw the profound impacts of generational poverty and racism in New Orleans and became deeply involved in local reproductive justice organizations, such as our Medical Students for Choice chapter, the formerly known New Orleans Abortion Fund, which is now the Louisiana Abortion Fund, and was able to participate in and see the development of the Louisiana Coalition for Reproductive Freedom, where I was the medical student member. When I started looking into OBGYN residency programs, I knew that I wanted a program that prioritized family planning training, and thus was ecstatic when I matched at the University of Hawaii, where I received amazing mentorship and training from other AANHPI providers and worked closely with AANHPI patients. This program and this training inspired me to pursue further training through a complex family planning fellowship at the University of Washington, from which I have recently graduated and am now proud and honored to serve as an assistant professor, as you heard in my biography. I provide full spectrum reproductive health care and I'm honored and excited to be able to do that. Throughout my training, people have often supported the idea behind the work that I do, but have frequently asked me why this work needed to be done by me specifically. And I've thought about this a lot and have finally realized that it is because I bring a unique identity, perspective, and lens to abortion work. As a Chinese, Malaysian, American woman, I am able to talk about abortion care, both as a member of the AANHPI community as well as a provider, and can start to understand the cultural challenges and differences that AANHPI reproductive age people face in seeking reproductive health care and specifically abortion care. Being part of this study's community advisory board has meant that I am able to further contribute my unique experiences and expertise to the field of medication abortion research within the AANHPI community, and this has allowed me to connect with the community in a way that I have not before. This work is particularly important because there is a lack of data on this particular community, where we're often consolidated either with other minorities or thought of as the model minority and thus similar to white patients. Sexual and reproductive health, particularly abortion care, are often taboo in AANHPI communities. So talking about this topic and allowing people to share their experiences and thoughts in a safe space is crucial. I am honored to have been asked to help guide this research project and appreciate this time to debrief the main findings from our study.
Thank you so much, Dr. Chin. We really appreciate hearing your thoughts and reflections, your career experiences on this topic. And we look forward to welcoming you back for our Q&A session later on in the presentation.
Thank you.
All right, so I'm really delighted to introduce our next speaker, who is Catherine Key, Senior Research Manager at Ibis Reproductive Health. Catherine manages both quantitative and qualitative projects at Ibis, including Free the Pill, a project to help make birth control available over the counter without a prescription. She oversees research projects focused on increasing access to safe abortion in abortion care in restrictive settings. Our research project today would not have been possible without Catherine and the Ibis research team. Catherine will present background findings from our medication abortion research project, and after her presentation, we'll be back to answer your questions. In the meantime, please drop your question in the Q&A window, and we'll do our best to answer as many of them as possible. So with that, thank you and welcome, Catherine.
Thank you. Great. All right. So the term AANHPI represents a vibrant and diverse population comprising of more than 50 ethnic subgroups and 100 languages and dialects. Next slide, please. Despite this diversity, limited research exists which recognizes and disaggregates data by ethnic subgroup. In fact, the limited research, including AANHPIs, that does exist, often groups AANHPIs into an other category, thus masking important health differences among AANHPIs. In doing this, research also fails to acknowledge the unique cultural and geographic histories of AANHPI people. What research does exist has shown that abortion rates differ among AAPI subgroups and indicates that Asian women are more than twice as likely to choose medication abortion over other methods because they felt it was safer. Prior research has also reported that AAPI women believe that women should have the right to make their own reproductive choices. Despite this, there continues to exist large gaps in our understanding of AANHPIs, knowledge of, attitudes towards, or experiences with medication abortion, and how these experiences intersect with community attitudes and values regarding sexual and reproductive health and abortion. Next slide, please. As we discuss this study, I'll refer to two types of abortion. The first is medication abortion, which is commonly referred to as the abortion pill. There are two types of MA, both safe and effective abortion methods. The first type of MA consists of taking two medications, first mifepristone followed 24 to 48 hours later by one dose of misoprostol, and the second type involves taking 3 or more doses of misoprostol 3 hours apart. MA can be used throughout pregnancy. However, most clinics in the US provide MA up to 10 weeks of pregnancy. I will also refer to procedural abortions, sometimes referred to as surgical, in-clinic, or suction or aspiration abortion, which takes place in a medical office or clinic by a medical provider who uses instruments to remove a pregnancy from the uterus. Next slide, please. So to fill this very large gap in the current literature, we conducted this study which aimed to assess AANHPIs' knowledge of and attitudes towards medication abortion within and across subgroups, countries, and generations, understand how AANHPIs access medication abortion and the pathways to accessing medication abortion, document the experiences of AANHPIs using medication abortion in the US, and recommend ways to improve and increase access to medication abortion at the individual, community, and health systems levels. Next slide, please. This study utilized a mixed methods, community-based participatory research approach to uplift and center the voices and perspectives of the communities involved in the study. From September 2021 to February 2022, we conducted focus group discussions and in-depth interviews with people of reproductive age who self-identified as Asian American, Native Hawaiian, and/or Pacific Islander or mixed race, including AANHPI. The focus groups were conducted in English and non-English languages to understand community perspectives and attitudes towards abortion. In-depth interviews were conducted with people who had a medication abortion within 5 years of participating in the study to better understand their experiences accessing medication abortion in the US and the barriers they faced during their journey. We also carried out a 15-minute survey in September 2022 with 1,500 AANHPI people of reproductive age and aimed to include roughly equal numbers of Asian Indian, Chinese, Filipino, Korean, Vietnamese, and Native Hawaiian or other Pacific Islanders. It's important to note that we were unable to recruit anyone who identified as NHPI to participate in an in-depth interview, and only 1% of our focus group participants identified as NHPI. So our qualitative findings primarily speak to Asian and Asian American experiences, although we will continue to use AANHPI to describe our findings and hope that future work can focus on understanding the unique abortion needs and perspectives of NHPI people. Next slide, please. As Isra mentioned, we also worked closely with a community advisory board, which consisted of 7 members from community-based organizations and experts on AANHPI issues. Several CAB members were selected to represent subgroups of interest, including Southeast Asian, Pacific Islander, and LGBTQ+ communities. Members served as advisors throughout the research process and were involved in each step of study design and implementation, as well as interpretation and dissemination of our results. Next slide, please. We would also like to thank the Society of Family Planning Research Fund for funding this study. Next slide, please. So in-depth interview participants' ages ranged from 20 to 43 years with an average age of 28. Focus group discussion participants ranged in age from 18 to 46 years with an average age of 27. We also conducted non-English focus groups, and of the participants, 40% spoke a primary language other than English. Among survey respondents, ages ranged from 16 to 49 with an average age of 33 years. Just over half of the respondents in our survey were foreign-born, and slightly more than half had previously given birth. We were able to recruit approximately equal numbers of people who identified as Asian Indian, Chinese, Filipina, Korean, Vietnamese, and NHPI, which resulted in 85% of respondents identifying as Asian and 17% of survey respondents identifying as NHPI. Among the survey respondents who identified as NHPI, a majority identified as Native Hawaiian, 13% identified as Samoan or American Samoan, 12% identified as another Pacific Islander subgroup not listed, and 6% identified as Guamanian or Chamorro among the pre-populated list of subgroups. Next slide, please. I'd like to now share some of our key findings from this report. So next slide, please. So from interviews and focus group discussions, we saw ways in which community attitudes towards sexual and reproductive health topics influenced abortion attitudes, knowledge of abortion and abortion methods, and overall experiences seeking abortion care. Many participants emphasized the taboo nature of SRH topics, including abortion, and shared that these topics are often treated as secretive in their communities. Participants further shared how, in addition to the taboo and secretive nature, a lack of openness around SRH topics led to decreased knowledge of and misinformation surrounding abortion methods. Interview participants specifically shared how this lack of knowledge then led to challenges and barriers during their decision-making and care seeking because they did not know about different methods or where to go for care, despite having come to the decision to have an abortion quickly. Further, participants shared how the stigma related to sex outside of marriage and pregnancy outside of marriage in some communities, in addition to the stigma surrounding abortion, negatively impacted the overall abortion experience and led to interview participants feeling isolated during and after their abortion. It's important to note and interesting to note here as well that sex and pregnancy outside of marriage was equally or more stigmatizing than abortion in some communities, and in some cases contributed to the decision to have an abortion in the first place, which was then not disclosed to family members or community members due to additional abortion stigma. This Vietnamese IDI participant shared, "Both my parents just scared me away from sex at all. So I was a pretty late bloomer in life because of it. But those were the values that I grew up with. Very anti-abortion, very anti-sex, no relationships because your only relationship should be with God." Next slide, please. So to help guide advocacy efforts and further understand preferences for information sharing on these topics, we asked survey respondents specifically where they would go if they needed information about SRH topics. And the top two sources from the pre-populated list of resources were a doctor or healthcare provider and an online resource. In interviews and focus groups, we similarly learned that participants overwhelmingly turned to online resources such as Google for SRH information. Participants also stressed, however, the importance of community resources that are close to or within AANHPI communities, and the importance of in-language resources from trusted organizations and at clinics. IDI and FGD participants additionally reflected on their positive provider interactions and shared ways that the interactions could have been improved if providers gave comprehensive information about abortion methods and what to expect during the abortion, and also provided non-judgmental and culturally sensitive care. Next slide, please. These quotes further illustrate the use of online sources and lack of community resources. A Filipina IDI participant said, "We looked on Google pretty extensively. I Googled what are abortions like because I think there's so much societal secrecy about them. It's very painful actually just emotionally that it's so limited in information that I actually had no idea what really happened." And a Japanese IDI participant shared, "There's not really any resources even in our local Japantown. There's not even any literature about medical or medication abortion." Next slide, please. So this figure shows the limited knowledge of abortion methods, specifically MA, among survey respondents. As we can see, almost half of survey respondents did not know where to go to access MA if they needed it. 40% had no prior knowledge about the safety of MA, and 35% had not heard about the method at all or were not sure. Qualitative participants further spoke to the information they heard about abortion in their communities and lack of knowledge of medication abortion specifically. When we provided information about medication abortion, however, participants in focus groups thought they would prefer this method over others because they believed it was easier, less invasive, and more private. Next slide, please. Again, these quotes demonstrate the misinformation, particularly related to prior beliefs of procedural abortions and why they would prefer MA. A Korean focus group discussion participant said, I've only heard that medication exists, and I don't know much about the side effects, but when I heard about it, I think I was personally relieved. If you watch movies or TV, there are so many abortions that are shown to be so violent. So if I have to make a decision like that, I would definitely choose medication. You can do it privately in your own private room, and you just swallow pills. And an Asian American focus group participant shared, in my family, medication abortion would be the preferred method because it's less invasive. And I think the ability to do it from home or go to a clinic and take the pill and then come home for the recovery period, I think that would make more sense. Next slide, please. So finally, this study highlights important barriers that AANHPI people face accessing abortion care, in addition to barriers that have been identified among all abortion seekers in prior literature. We know that all abortion seekers experience high cost of abortion care and lack of insurance coverage, limited appointment availability, and legal restrictions, among many others. And although these barriers are commonly cited among abortion seekers generally, some barriers, such as the high cost of abortion care, may be particularly devastating for the large populations of AANHPIs living in states that severely restrict Medicaid coverage of abortion, making it challenging for low-income AANHPIs to pay for their abortion. In addition to the common logistical and financial barriers, participants in the qualitative study identified community-specific barriers such as stigmatizing attitudes towards abortion and SRH topics broadly, as well as a lack of family support, which led to challenges accessing information and feelings of isolation during the process. Participants also described how, due to stigma, many people choose not to disclose information about their abortion to their family, which led to additional challenges because some participants live with or near family members, for example, making it difficult to leave to access care or manage symptoms from medication abortion at home. And finally, participants highlighted the lack of Asian and NHPI language options at clinics as barriers when accessing care and looking for information about abortion. Next slide, please. So this NHPI focus group discussion participant highlights both travel-related challenges and a lack of availability of clinics in Hawaii. They said, I think the obvious barrier is knowledge of this, referring to medication abortion. Like if somebody grows up only thinking abortion is, oh, the doctors are going to slice you open and take the fetus out, that's one thing. Another, I think, is distance to travel, and not everybody has access to a car, and not all public transport goes close enough to an abortion facility or an abortion provider. Like I think Hawaii has one Planned Parenthood. The South Korean IDI participant also highlights both general and AANHPI community-related barriers and says, I wasn't able to make the abortion appointment in the time that was appropriate for me because I wanted to do it as soon as possible. So I had to make an appointment in a different city and drive an hour and a half to get there, which made it more difficult. On the night that I took the abortion pills, I booked a hotel because I did not want to go through it at home. I was living with my parents at the time, so it was an extra cost and also an extra work. Next slide, please. So 61% of survey respondents who had a medication or procedural abortion also reported community-related barriers they experienced accessing care, particularly personal or religious or moral concerns about abortion method type, challenges because someone close to them did not want them to have an abortion, and barriers related to arranging childcare or care for another family member, which is also common among all abortion seekers. Given the prevalence of financial and logistical barriers experienced by abortion seekers generally, it is likely that these community barriers that are highlighted by our participants are experienced in addition to barriers like the cost of the procedure and or travel-related challenges. Next slide, please. These quotes from IDI participants demonstrate the ways community and cultural views of abortion compound challenges people face accessing abortion care and result in feelings of isolation. An Asian Indian participant shared, I feel very isolated, like I pretty much carry this experience with me and only me right now, but I've never really talked about it to my family. So during that time, nobody knew. I don't know if barrier is the right word because I feel like I was going to have to find a way regardless. So I think maybe it's not a barrier, but it just kind of sucked having to go through that alone. And a Japanese IDI participant said, there's such a taboo in us even talking about abortion. If I had a greater acceptance to freely talk about it, then I probably would have had a better general understanding about what a medication abortion would have meant. Next slide, please. So as findings from this study demonstrate, there is a salient stigma towards sexual and reproductive health topics, especially abortion among AANHPI communities, that often leads to detrimental knowledge gaps about abortion methods, especially medication abortion. These gaps in knowledge and the cultural stigma are further exacerbated by lack of available and accessible information in Asian and NHPI languages when navigating clinics and other healthcare settings. This ultimately leads people to feeling isolated during their abortion process despite wanting additional support. So in terms of next steps and recommendations, it's important to continue to collect and publish disaggregated data and research on sexual and reproductive health for AANHPI subgroups. And findings from this study also demonstrate the need to increase access to reliable and accurate information about abortion methods in ways that are culturally sophisticated and in language that can be distributed by community-based organizations to help dismantle stigma and common misconceptions and misinformation related to abortion care. And in doing this, we need to build support for community-based organizations and providers to be able to successfully distribute this information. Finally, we need to normalize the experience of abortion as a part of healthcare and ensure culturally competent care within the healthcare system. Thank you.
Thank you so much, Catherine, not only for the presentation, but for your work over the past 2 years. And as you were speaking, what really resonated with me were the quotes that you shared. Hearing you verbalize them was really powerful, and it really resonated with me because I really identify with what was said. And I know for myself, cultural stigmas about sexual and reproductive health is something that started on early on in my adolescence, and I think these experiences of isolation and secrecy, not just for me, but for many in our community, continue well on into our adult reproductive lives. So it's not surprising at all to hear you talk about this reality when it happens over and over again and can lead to serious and detrimental knowledge gaps about abortion. The barriers you mentioned, like the lack of family support and the dearth of language options, shows how cultural stigma is further exacerbated when Asian American, Native Hawaiian, and Pacific Islander patients are seeking help in navigating abortion care inside clinics and healthcare settings. So from a policy and practice lens, the recommendations you highlighted in your presentation really give us some direction on where to go from here. Yes, we need to do more research like this study that documents and centers the abortion experiences of our community. At NAPAWF, we anchor our work in the reproductive justice lens. And in the context of our current political environment, where abortion is stigmatized and rights are taken away, access remains critical in states and cities with large AANHPI populations. And when we look at this through an RJ lens, we think about the different intersections that impact abortion access within AANHPI communities. This includes language access, immigrant status, access to healthcare that create real challenges and setbacks, especially for low income and working poor communities who may perhaps live in communities with less robust public health programs. So I want to underscore how important, as you mentioned in your presentation, community-based organizations serving AANHPI communities are to addressing misconceptions to abortion care and also helping people and families get the care they need. All right, so before we take some questions, I'd like to welcome back Dr. Chin and Catherine back to the screen. And if you haven't done so already, please add some questions in the Q&A window. I see a few coming in. The first one I'll start off with is maybe directed more towards Catherine, and please feel free to chime in, Dr. Chin. But when you spoke to and interviewed AAPI women for the report, how comfortable were participants sharing their abortion stories and experiences? And then furthermore, are there things you remember that aren't or can't be captured in the report?
Thanks for that question, Isra. I think that comfortability with the questions and talking about their experience really depended on the person and their experience. But I think overall, people shared a lot of appreciation for being able to use this space and talk to someone about their abortion experience. I think the one thing that was challenging to capture in the report and in findings is the way that people expressed their gratitude for having this space. And in a lot of cases, this was the first time that they really had the opportunity to talk about their experience with anyone. So I think that was a really powerful thing for people.
Great, thank you. And I just want to note that I know there are a few questions coming in about the slides, so we will definitely share that after the conclusion of the presentation. So second question is, this is probably directed more towards Dr. Chin. As some states restrict abortion access or care, have you seen locations where med students select for training and jobs change? And also, have you heard reports of OBGYNs leaving restrictive states because of inability to provide abortion care, which obviously exacerbates inequalities in maternal mortality rates?
Thank you for that question. The short answer is yes to both of those. I will go back to my initial response to your question. When I was looking specifically for OBGYN training, I very much prioritized programs where I knew I would receive a full spectrum of training, including ones that focused on abortion care. And in talking with many medical students that I work with now, or people who I'm in contact with, medical students are having to make the very difficult decision of knowing that OBGYN is a very competitive field. And so in many cases, people are trying to apply to as many programs as possible, but in medical students who specifically want to receive abortion care training, they are having to decide if it's worth it to apply to other programs where potentially they will not receive that hands-on training, or it won't even be included as part of their formal hands-on curriculum. And so that makes the pool of places that they can apply much more restrictive. And as was noted in the question, there are also providers who have abortion training and feel very comfortable and feel very passionate about providing abortion care, but because of restrictive state laws are no longer able to provide that care for their patients. And so they feel that their hands are tied and they're not able to provide evidence-based, compassionate, full spectrum care, and so are leaving either their home state or a state where they had intended to practice because they specifically wanted to be able to provide abortion services in those states. And so all of these restrictive, hostile state environments are having major rippling effects, where it's not only affecting abortion care within that specific state, but is also depleting the pool of OBGYNs who provide compassionate, non-judgmental care, and is driving both patients, providers, medical students, and residents to these states where abortion is still accessible, and is just going to affect people who are capable of pregnancy in many, many different ways.
Thank you for that. So our next question is more about messaging in the study. So the question is, did the study find particular messaging that was effective to use to talk about abortion with different AANHPI groups?
Thank you. That's a great question. I think that based on the way our study was structured, we didn't test out specific messaging or ask about different ways to talk about these with our participants, but I think that would be a great step for future work to be able to understand how to better communicate this. I think our study really just highlights the gap and that there is this need to share more information in culturally sensitive and appropriate ways, as well as in language.
Thank you, Catherine. And I will say that sounds like maybe a second part to the study. All right, let's go for one more question. This is a bit of a softball question I think both of you can respond to. Is what surprised you the most in your findings and talking with the participants?
All right, I think I can start. I think we know that there is stigma related to these topics. And I think we all have our own experiences in not being able to talk about these topics in our personal lives and experiences. But I think it was surprising and interesting to see how this was salient across different subgroups and experiences, generations, and just people in our study, and just seeing the ways that this is so prevalent among these communities and how this really intersects with the actual experience and ways that people had access to the information.
I can add that I was maybe pleasantly surprised that when participants were asked for where they would first turn to seek information, that the top response was a provider or a doctor. And I think that this really goes to show that providers need to be trained in ways that are helpful to communicate with the AANHPI community, and making sure that we are culturally sensitive and taking into account the unique needs of this population.
Thank you both. It looks like we have time for one more question. So the last question is, how do we challenge and change cultural stigma so that younger generations do not have to go through what we went through?
I cannot start us off again, but I would love for others to jump in. I think what we saw in our study and among our participants, people really wanted additional support and ways to be able to talk about their experiences and share information. So I think it would be great to have additional support groups that are specifically geared toward AANHPIs to be able to share their stories and feel like this is not something they're going through alone, and really normalize it within their communities. And I think that would also help if community-based organizations were also involved and able to share some of these resources. People really seem to trust their community-based organizations, trust their providers, like Dr. Chin said. So having more available options in clinics and at these locations, I think would help bridge some of the knowledge gaps and also start to dismantle some of the stigma.
I agree with you, Catherine. I think this is not something that's going to happen overnight, but just the more that people can talk about abortion as an option when someone presents with an early pregnancy, and the more that people are able to talk about their own abortion experiences, the more that providers are able to counsel in the full range of options when someone presents early in pregnancy, then it can become part of our normal discourse and something that's not so stigmatized and taboo, and something that needs to be carried out in secrecy. And I think that the more that people feel comfortable sharing their own experiences, the more that other people can feel like they're able to seek support within their own community.
Well, yes to all of that. In NAPAWF, we're doing a lot of work, just zooming out, broader work on narrative shift and about, who we are as Asian Americans, Native Hawaiians, and Pacific Islanders, and also lifting up that obviously medication abortion access is all healthcare. So those are all the questions that we had for today. I'd like to thank Catherine and Dr. Chin for taking time out of their day to speak about this report and just all of your work in partnership with NAPAWF. So on behalf of NAPAWF, our CAB members, and Ibis Reproductive Health, thank you for joining us today. It's important to recognize that medication abortion is a safe, effective method that the study highlights, and is an option that allows Asian American, Native Hawaiian, and Pacific Islander people to start to chip away at some of the barriers they face when seeking abortion care, including combating cultural stigma. As an organization that organizes and builds community on the ground, part of our intention in releasing this report is to open up honest dialogue among community members around abortion care. This report has shown us that AANHPI women need and deserve authentic and open conversations about our health and access to information and resources on where to find care. To that end, NAPAWF will be holding community-led events in some of our chapter states in the coming months. These events will not only highlight research, but offer a space for participants to share their own impressions of the findings and stories from their own lived experiences. To stay up to date on these and future events, as well as the changing landscape of abortion access and reproductive justice, please sign up for our mailing list by visiting napawf.org, as well as ibisreproductivehealth.org. You can also follow us on our social media channels. Our full report, titled Medication Abortion Among Asian Americans, Native Hawaiians, and Pacific Islanders, Knowledge, Access, and Attitudes, is now available on our website at napawf.org. Thank you again for spending part of your day with us, and please take care and be well.